Great, thanks so much. And I would just echo what they said. Please come forward. We can have an intimate discussion. All right, so I'm going to talk about environmental risk factors for ARDS. These are my disclosures, the only one of which is related is that I have funding from the NIH and the FDA related to smoking and ARDS. So this is actually the topic that got me interested in research when I was a pulmonary fellow, is trying to understand why it is that only some of the many patients who have ARDS risk factors like sepsis, pneumonia, or trauma actually go on to develop the syndrome. And so today I'm going to talk about 3 environmental risk factors, specifically alcohol, tobacco products, namely cigarettes, and air pollution. I'm not going to cover other non-modifiable risk factors like race, ethnicity, or genetic polymorphisms, just in the interest of time. Let's start with alcohol. And this was really a seminal study published by Mark Moss and JAMA in 1996 for several reasons. First, because it was the first study to demonstrate an association between alcohol and ARDS, but also because it was really the first study to address this idea that what happens, what a person's lifestyle habits or what's happening in their environment might actually influence their ARDS susceptibility. This was a cohort study of 351 patients at risk for ARDS, and they found a relative risk of almost 2 for ARDS in people who had what we now call alcohol misuse, then called alcohol abuse. As you see on the left-hand side in the figure, this risk was slightly higher in patients with sepsis compared to other ARDS risk factors. They also found a higher mortality rate with ARDS in patients who misused alcohol, and interestingly, they did not report any smoking data in this paper. Since that time, there have been a number of different studies evaluating the association between ARDS and alcohol that have confirmed this increased odds or increased risk in some cases of developing ARDS in patients who are alcohol abusers. And you can see a summary of those, some of those seminal studies on this slide. I don't have time today to go into all of the bench research that sort of went into the mechanisms of this association. But suffice it to say, there's been a fair number, a lot of it out of Emory and now University of Colorado, trying to understand how it is exactly that alcohol predisposes to ARDS. And the consensus seems to be that basically alcohol abuse leads to relative depletion of glutathione stores, which then increases TGF-beta expression and activation, leading to impaired lung epithelial barrier function and therefore increased susceptibility to lung injury in the setting of a risk factor. Okay, so this is alcohol. What often goes with alcohol? Cigarette smoking. And there's certainly a lot of biologic plausibility that smoking and ARDS might be related. There were first studies in the actually 1980s that showed that smokers had more permeable lung epithelium at baseline in a state of health compared to non-smokers. We know from the cardiovascular literature that smoking leads to both epithelial activation as well as platelet dysfunction. And smoking has direct effects on both humoral and cell-mediated immunity that may influence infection susceptibility and response. So what do we know about the data? Well, this was a study that we published in the Blue Journal back now 8 years ago in patients who had severe blunt trauma. We measured cotinine, which is a very well-established biomarker of cigarette smoking. It's a metabolite of nicotine. And we found that as cotinine or cigarette smoke exposure increased, there was what almost seemed to be a dose-response increase in the proportion of patients who developed ARDS. And this association was independent of injury severity, and also importantly, independent of alcohol abuse. And certainly, as I said, those 2 factors go together. Since that time, there have been a number of other studies on this topic. Interesting, there's a little bar there. I don't know what that is, but what that says is transfusion-related acute lung injury. So this was Pearl Toy's group that found that for trolley, there was an association with history of smoking and ARDS development in multivariable models independent of alcohol abuse. Jason Christie's group found that there was an association between donor smoking and primary graft dysfunction, which is basically ARDS that occurs after lung transplant. Again, in a multivariate model, this was an independent association. And then more recently, our group reported that there was an association between biomarker-defined smoking and ARDS in the setting of non-pulmonary sepsis. again, independent of other ARDS predictors. So the epidemiologic data seems to be relatively consistent across a variety of different settings and risk factors for ARDS. What about ARDS outcomes? So this is a little bit of a different question. I've been talking to you about susceptibility, but is smoking associated with different outcomes from ARDS? And this is work that was led by a woman named June Shea, who was a fellow of mine, now faculty in New York City. She did a secondary analysis of 381 patients from 2 large ARDS clinical trials, the ALTA trial of inhaled albuterol for ARDS, a negative study, and the OMEGA trial, which was a trial of omega-3 fatty acid supplementation. And we measured smoking status using a biomarker called urine NNAL, which has a relatively long half-life. It's a tobacco-specific nitrosamine that's produced in the tobacco curing process. And what she found is that smokers were markedly younger than non-smokers with ARDS, by over a decade, actually. And interestingly, smokers had many fewer comorbidities than non-smokers. They were much healthier. So they were much less likely to be immune suppressed, to have diabetes, MI, hypertension, heart failure, stroke, almost you name it. They were significantly less likely to have these comorbidities, with the exception of COPD. In addition, as I'll show you on the next slide, they had less severe acute disease and were less likely to be in shock at the time of enrollment. Yet, despite that, they had similar severity of lung injury. So I just want you to focus at first on these first 3 lines. These are patients divided into 3 categories. So non-smokers, passive smokers, and active smokers, again, using this urine biomarker. And if you look first at the Apache score, you'll see that the active smokers had lower Apache scores, much lower actually. So they were less acutely ill, less likely to be on vasopressors at baseline, and less likely to be in septic shock. Yet, despite this much lower acute severity of illness, they had very similar severity of lung injury and similar PF ratios. So this is, again, consistent with the hypothesis that smoking is somehow increasing susceptibility to ARDS at a lower level of injury. What about clinical outcomes? Well, we were super surprised to see this data. Actually, it turns out that active smokers have much better clinical outcomes from ARDS than non-smokers. So 60-day mortality, 15% in the active smokers versus 29% in the non-smokers, and sort of an intermediate value for the passive smokers. And similar patterns in ventilator-free days and organ failure-free days. So why is this? Is smoking saving people from ARDS? Well, probably not. So when you adjust for that younger age, that lower illness severity, and their comorbidities, this association goes away. And it turns out that this is exactly the same pattern they see in the setting of acute MI, where it's referred to as the healthy smoker effect or the smoker's paradox, with the idea being that smoking is such a prominent risk factor for coronary disease that it sort of overwhelms the effect of these other factors and puts even people who are at lower risk into a disease category. So this was an interesting phenomenon, and again, I think consistent with the primary underlying hypothesis. In the past few years, we've been studying this association in animal models to see if we can confirm the epidemiologic association, and this work has been led by Jeff Gotts, who's a terrific young physician scientist who works with us at UCSF, and we've now confirmed this association in 2 different lung injury models, so in an endotoxin or LPS lung injury model, as well as in a pneumococcal pneumonia model that's treated with antibiotics. We see that cigarette smoke exposure prior to injury worsens the severity of lung injury. This is a sample figure on the right in which the y-axis is excess lung water, which represents pulmonary edema. And you can see here that the animals that are exposed to cigarette smoke prior to LPS have more pulmonary edema compared to the air-exposed animals. So this is additional confirmation of the epidemiologic findings. I don't have time today in 15 minutes to tell you much about the mechanistic associations here, but I'm going to just show you a few highlights. As we've been trying to understand the mechanisms of this association with the idea that it might help us identify targeted therapies. So one approach we've been using is to study explanted donor lungs. So these are lungs that are offered for lung transplant but are not used because of various reasons for the donor and sometimes of the lungs. And when we bring them to the lab and study them, we found that lungs from smokers have more pulmonary edema, so they're heavier compared to lungs from non-smokers. And interestingly, in the heaviest smokers, they actually have lower alveolar fluid clearance. That's the ability of the lung epithelium to clear fluid from the air spaces. Again, consistent with the hypothesis that smoking may predispose to lung injury. We've also been collaborating with Danny McCauley, who has this really amazing LPS inhalation model of lung injury, in which healthy volunteers inhale LPS and then undergo research bronchoscopy. It's actually a safe and relatively well-tolerated model. And in that model, we found that smokers have exaggerated inflammatory response as well as more epithelial barrier dysfunction in response to inhaled LPS. And then finally, in some of the most recent work, we've been studying the lung microbiome and published this work in the Blue Journal last year, in which we found that in critically ill trauma patients, the same patient population I started with, the lung microbiota differed in smokers and non-smokers and was associated with ARDS development. So that's a very quick sort of 30,000-foot view of the potential mechanisms of this association. All right, so in the last couple of minutes, I just want to talk about a different and more novel area of study for us, and that's air pollution. And we became interested in this because obviously cigarette smoke and air pollution have some of the same constituents, including particulate matter, ozone, and others. This is a picture taken across San Francisco Bay with Alcatraz Island in the foreground from November of this year. Some of you may know we had terrible catastrophic forest fires in Northern California, and it generated extremely intense air pollution to the point that you could actually barely see, you really couldn't see across the bay, which is normally crystal clear. So in the era of climate change, this is going to be, I think, something we all have to be increasingly aware of. What are the health effects of this air pollution? So our first study on this was a collaboration with my good friend and colleague, Lorraine Ware at Vanderbilt University, who has a large observational cohort of patients with and at risk for ARDS. And we measured air pollution exposure both in short and long term in patients in this cohort and found that actually long term, and by long term I mean the 3-year average ozone exposure, was associated with an increase in ARDS risk in all ICU patients, as you see here in the top, and particularly so in trauma ICU patients. We were really worried that this might be confounded by other factors associated with air pollution in the patients, and so we controlled for really a huge variety of different potential confounders and found that this association was really robust despite controlling for all of those factors. Interestingly, there seems to be what we call an interaction with cigarette smoke exposure. So that means that the effect of air pollution seems to be different in smokers and non-smokers. Again, here we have ozone level on the x-axis and predicted risk of ARDS in the y-axis. And you can see that this relationship seems to be particularly strong in smokers, which makes sense biologically if similar mechanisms are applying here. I also want to point out that the levels of ozone exposure here are actually quite low. So all of these levels of exposure are well below the US EPA recommended limits for ozone exposure, and that was even before our dear president destroyed the EPA. So this was in the pre-Trump era. These are still relatively low levels of ozone exposure, and yet we're seeing this increased risk. We recently expanded this work in a collaboration with John Riley and colleagues at University of Pennsylvania in a cohort that has much more granular exposure assessments. So exposure stations are not distributed randomly in the US. They're concentrated in certain areas, and around Philadelphia there tend to be many more exposure measures. And so we were able to get much more precise estimates of exposure, and it turns out when we did that, we actually found strong associations with several different pollutants in ARDS. So PM 2.5, which is the small particulate matter that gets deep into the alveolar space, carbon monoxide, sulfur dioxide, ozone again, and nitrogen dioxide. And again, when we controlled for all of these risk factors, these associations were not attenuated. All right, so in summary, take-home points, there's strong epidemiologic and experimental evidence that both alcohol and smoking are associated with increased ARDS susceptibility. The mechanism for alcohol may be mediated via glutathione depletion, and for smoking, I think there are multiple potential mechanisms, including an exaggerated inflammatory response, epithelial barrier dysfunction, and potentially changes in the microbiome. There's emerging evidence of this link between air pollution and ARDS, so stay tuned for more on that. And I don't have time to tell you about it today, but we are currently working on e-cigarettes and whether or not they may have acute pulmonary toxicities that may predispose to ARDS. So with that, I'll close, and I'm happy to take any questions. Thanks.